Management of ulcerative colitis, UC. Ulcerative colitis, UC, is a chronic inflammatory condition of the colon and rectum characterized by recurrent episodes of mucosal inflammation. Its management focuses on inducing and maintaining remission, improving quality of life, and preventing complications. Below is a detailed outline of the approaches to managing UC. 1. Assessment and classification. Management depends on the severity, extent of the disease, and the patient's response to therapy. UC is classified as mild, fewer than 4 stools per day, mild cramping, no systemic symptoms, and normal inflammatory markers. Moderate, more than 4 stools per day, minimal systemic symptoms, and elevated inflammatory markers. Severe, more than 6 bloody stools per day with systemic toxicity, fever, tachycardia, anemia, elevated ESR-CRP. Pharmacological therapy. Treatment is aimed at achieving remission, induction therapy, and maintaining remission, maintenance therapy. A. Aminosalicylates, 5-ASA. Indication: first-line therapy for mild to moderate UC. Agents: mesalamine, sulfasalazine, balsalazide. Route: oral or rectal, suppositories, enemas depending on disease location. Effect: reduces inflammation by inhibiting prostaglandins and leukotrienes. Adverse effects: nausea, diarrhea, and headache. Sulfasalazine may cause hypersensitivity or folate deficiency. B. Corticosteroids. Indication: moderate to severe flares or failure of 5-ASA therapy. Agents: prednisone oral, budesonide topical oral, or hydrocortisone IV for severe flares. Effect: potent anti-inflammatory action. Adverse effects: weight gain, hypertension, hyperglycemia, osteoporosis, not recommended for long-term use. C. Immunomodulators. Indication: for steroid-dependent UC or as maintenance therapy in moderate to severe cases. Agents: azathioprine, mercaptopurine, 6-MP, methotrexate. Adverse effects: bone marrow suppression, hepatotoxicity, pancreatitis, risk of infections. D. Biologics. Indication: moderate to severe UC unresponsive to conventional therapy. Types: anti-TNF agents, infliximab, adalimumab, golimumab. Integrin inhibitors, vedolizumab, IL-12/23 inhibitors, ustekinumab. Adverse effects: risk of infections, infusion reactions, and malignancy. E. Janus kinase JAK inhibitors. Indication: moderate to severe UC when biologics fail. Agent: tofacitinib. Adverse effects: increased risk of infections, thromboembolism, and hyperlipidemia. 3. Supportive and adjunctive therapies. Antidiarrheals, e.g. loperamide for mild diarrhea, avoided during active flares. Antibiotics, for complications like pouchitis or coexisting infections. Iron supplements, for anemia due to chronic blood loss. Calcium and vitamin D, to prevent osteoporosis associated with corticosteroid use. 4. Nutritional management, dietary modifications. Avoid high fiber or trigger foods during flares. Maintain a well-balanced diet during remission. Nutritional support, enteral or parenteral nutrition in cases of severe malnutrition. 5. Surgical management, indications: failure of medical therapy, severe or fulminant colitis not responding to IV steroids or biologics, complications, e.g. perforation, severe bleeding, or toxic megacolon, dysplasia or colorectal cancer. Procedures: total proctocolectomy with ileal pouch anal-anastomosis, IPAA, most common surgery, preserving bowel continuity. Total proctocolectomy with permanent ileostomy in patients unsuitable for IPAA. 6. Monitoring and follow-up, regular clinical assessments. Monitor symptoms, stool frequency, and rectal bleeding. Laboratory tests. Complete blood count, CRP, and fecal calprotectin to monitor inflammation. Colonoscopy, at diagnosis and during remission to monitor disease extent and screen for dysplasia. Cancer screening, increased risk of colorectal cancer. Surveillance colonoscopy is recommended 8 to 10 years after disease onset. 7. Lifestyle and psychological support. Stress management. Stress can worsen symptoms. Counseling or therapy may be helpful. Smoking. Smoking cessation is not strongly associated with UC worsening, but remains essential for overall health. Physical activity. Regular exercise improves overall well-being. Support groups. Connecting with others facing similar challenges. 8. Management of complications. Toxic megacolon. Medical emergency requiring IV steroids, bowel rest, and surgery if unresponsive. Colorectal cancer. Surveillance colonoscopy and early detection. Extraintestinal manifestations. Treat symptoms such as arthritis, uveitis, or skin lesions, e.g., pyoderma gangrenosum. 9. Emerging therapies. Small molecule drugs. Ongoing research into new JAK inhibitors and sphingosine 1-phosphate, S1P modulators. Microbiome-based therapies. Fecal microbiota transplantation, FMT, and probiotics. Conclusion. Management of UC requires a personalized, multidisciplinary approach involving gastroenterologists, surgeons, dietitians, and mental health professionals. Advances in biologics and emerging therapies are expanding options for patients, particularly those with refractory disease. Regular monitoring and patient education are critical to optimizing outcomes.